Thanks very much, Tim. So we talked about a journey earlier, focusing, as Ian has, and I'll pick up really the early stages, the beginnings of the journey for people. And typically things start with a child who has symptoms, and at some stage the penny drops that there's more going on than just a normal headache or whatever, and a scan happens, and something's found on the scan, and then patient and family find their way in the direction of a children's neurosurgical team, not always smiling quite as happily in the hospital bed as in the cartoon there. Then you get introduced to someone like me, who comes along to have a discussion with you, and then at some point waves a consent form and discusses doing an operation. And as Ian's alluded to there, there's a lot to take into account when we're having that discussion and when we're looking at the consent form. We mentioned earlier, how much information do people want at the beginning of all of this? And we cannot possibly tell you everything that might happen. It's too much. What we're usually thinking about, you look at people like us and think, how do they do these operations? So we're thinking a little bit about the technical aspect of how we're going to do the operation, how much of the tumour we're going to try and take out, how we're going to get to it. We're also trying to think a little bit about the consequences of that. The common thing that comes through from families usually is, will you be able to take it all out? And that's driven by thinking around removal of tumours and a lot of other specialties, where the emphasis is usually on, oh, it's great, the surgeons managed to take it all out. And our standard phrases usually are, we will try and find out what it is, and we'll try and remove as much of it as is safely possible. And those are the two principles of neuro-oncological surgery, confirming a diagnosis and getting as much as is safely possible out. So the sort of things I'm thinking about in terms of the factors that are influencing the discussion I'm having with families and the way I plan and do an operation, there are tumour-related factors. So the size of the tumour, location, as we've said, is absolutely key. Where the tumour is, what it's next to. Invasiveness, whether it is stuck to something or whether it's just next to it. The grade, the blood supply can be key. How much it's bleeding while we're operating on it. The consistency of it, if it's soft and goes up the sucker very easily, that's great. If it's really firm and if it's stuck to everything and it's firm, that's really difficult. Whether there's already spread of the tumour beyond the primary site where most of the tumour is. Then there are factors related to treatment that will affect outcome, both in the early months and in the late effects. There's how resectable the tumour ultimately is, whether it turns out to be suitable for slightly less toxic biological therapies, or whether we have to use more traditional chemotherapies that will have more toxicities. Whether radiotherapy is going to be required, how focal and how controlled and conformal the radiotherapy can be. And there's factors that relate to the patient. Some patients arrive at our door looking absolutely fine neurologically. All they've got is a headache. We can't find anything wrong with them neurologically, and that's great. Some patients arrive who've already got lots of neurological signs and a big symptom burden already, and that may or may not get better with the steroids and then run up to surgery. So those are patient-related factors that we have no control over, but they influence our decision-making around the surgery and influence the late effects. Past medical history. Some patients arrive and they had no other problems before. Other people will arrive and they may have had other significant medical problems. They may have had pre-existing cognitive problems or mental health problems, and those things all contribute. And there's factors we're also trying to assess and take into account in the environment around the patient. Some families arrive and everyone in the family's well, and everyone in the family's together, and everyone in the family's happy, and that's great. But it isn't always like that. Sometimes, so that's within the immediate family. Some families have got lots of grandparents and lots of friends around about and lots of supports, and some people don't. There's geographical issues. Star mentioned earlier that she's from Skegness, which is the sort of furthest reaches of our region. It's 2 hours away if you're lucky, isn't it? And that makes a difference. If you live right next door to Queen's Medical Centre, it's really handy if we want you to just pop in to sign another form or have another blood test. If you live in Skegness, it's a bit of a day out. And there could be financial pressures. Some families have no financial worries at all, which is fantastic, but others have already got financial problems and pressures, and things are going to get worse if they're having to take a lot of time off. And there could be language issues. We have lots of patients who English is their first language, but we have lots of patients who English is not their first language, and they have varying degrees of ability to communicate with us and fully understand complex and nuanced discussions. I'm going to call up now some colleagues from the Neurorehabilitation team to talk about how they would tackle each of those factors. So here's Rachel and Mel.
Hi, everybody. I know Denise spoke a little bit about the pathway earlier, but from a neuro rehab point of view, we're then Donald's admitted the patient and then they're on the ward, and where possible, unless there's a very quick trip to theatre, then we would do an initial early assessment and baseline that child and be part of that team that's assessing that neurological status on admission. We have a full integrated multidisciplinary team, so we've got physio, OT, neuropsychology, speech therapy, everybody else. And as soon as the patient comes back from theatre, then as soon as we're medically stable, then we're straight in there with early intensive rehabilitation, early family engagement, proactive discharge planning, and really thinking about getting a child home as soon as they're medically fit to get home. So trying to make sure that therapy fit matches medically fit, and so that we know that children get better when they're at home, and so where possible we will get them home safely and with the right support in place to carry on their rehab at home. That might mean us coming back to the hospital or us arranging for community therapy out where they live, and then there's that ongoing specialist outreach and support from the team just to make sure that children are cemented into the services that they need, or if they aren't, then trying to bridge those gaps with us.
So after patients are discharged home, they're then reviewed in that specialist ABI clinic, and that's led by our consultant, Denise. But we've also got a clinic running alongside that, which is the specialist physio and neuropsychology. So some children are seen by the physio and neuropsychologist. And we also look at the Child Brain Injury Trust to kind of pick up some of that family support. Later down the line, a lot of children will have a neuropsychology assessment, and that will help sort of feed into return to education. So lots of liaison with school and education, and sometimes that's through kind of MDT meetings, making sure that the school have got enough information to support a young person to get back to school. It's such an important part of their life. Therapy will continue, and we do make early referrals to community teams with the hope that children can be picked up by services closer to home, because that's always kind of better in the long term. But sometimes there's a bit of a gap, so we will see those children as outpatients whilst waiting for community. And then also we'll think about referring that child to the community paediatrician, so that, again, they're picked up by local services. Some children from the acute hospital at Queen's will actually continue their rehab at a local district general hospital, and often that'll be if there's if the child is medically fit but still needs lots of rehabilitation, but maybe their family circumstances mean that they need to be nearer home, so we would refer to the local district general.
I really like this slide because I think it just really shows that actually rehab isn't just about after surgery, it's all the way through. So rehab needs to start in that preventative phase in terms of that screening and monitoring, and if there's going to be perhaps a delay for surgery or surgery is not needed quite straight away, it's about making sure we keep that child as strong and as fit and as active as possible. So the real role in preventing mobility decline or anything before surgery, but also in terms of preventing longer term issues as well. Obviously it's supportive, and one of the big factors we have to factor into rehabilitation for children with brain tumours is chemotherapy and radiotherapy, and the impact that has on the child's ability to engage daily with that therapy. So sometimes it's a bit more supportive and we just do what we can when we can. We're trying to restore and try and alleviate the impact of those functional impairments. But there's also a role within palliative care as well, and making sure that we maintain function and quality of life for as long as possible if a child is moved on to a palliative phase of care.
So this slide just sort of summarises some of the rehabilitation interventions. So within kind of the hospital setting, some of the things that we'd look at are motor relearning. So that might be your what you might think of as the typical kind of physical physio session, or it might be to do with kind of swallow. The speech and language therapists might get involved around kind of that kind of oral stage. And we'd also look at kind of cognitive, psychological function. And that might include kind of early assessment with the neuropsychologist. We're all about promoting independence, so where possible, encouraging children to do as much for themselves as possible, and sort of passing that message through to parents with advice and education around how they can help and support their child. We also look at postural management, so protecting those joints and those, soft tissues so that we don't get any contractures where possible. Sometimes includes equipment provision in the hospital, and sometimes that can be kind of planning ahead for discharge home. Like we said previously, always got an eye on return to school and activities, whatever those activities might be. For that child, whether it's kind of return to some kind of sport or school, and really trying to harness what that child's interests are for the therapy sessions as well. And like I said, lots of advice and education both to the child and young person or to their families. And I think lots of people have spoken about this MDT, absolutely, lots of liaison. We have our weekly meetings. And then kind of thinking about the long-term effects and palliative care where that's appropriate. So we have lots of interventions, and really we tailor them to what the child's needs are at the time.
So we want to just briefly discuss 4 cases. I'll start by summarising what was the presentation, the surgery, and then really how the after effects have unfolded since then. So first up, we've got a little lad who's 8 years old, who we saw earlier this year, very small, short stature. He turned out to have isolated growth hormone deficiency, and actually on testing, although no one had noticed, he got a bitemporal visual field defect, so he couldn't see out to the sides. And when he was scanned, he turned out to have a craniopharyngioma, so a midline tumour next to the optic chiasm, which was why his vision wasn't right. And that had affected his growth hormone production, but no other aspect of his hormone production at that point. So from the family's point of view, initially they'd been giving him growth hormone replacement, and that for them had addressed the issue. He was growing again. And he was actually someone who'd been living elsewhere who came to the UK, where when he said, "Can I have some more growth hormone, please?" people went, "No," not until we found out why. So having discovered there was a reason and then trying to do something about it, we had to get the family on side that we wanted to try and stop his vision deteriorating. Probably couldn't do much about the fact that he needed growth hormone replacement already. And we spoke at length with them about the fact that he may well need further hormone replacements after we'd done what we could about the tumour. It was, in fact, an extremely calcified craniopharyngioma, very stuck to everything round about. And Lawrence Glanks, who was here earlier, who's had to go now, who's one of our adult endonasal transsphenoidal experts, he and I and one of the ENT surgeons went up the nose to remove this in the way that Ian showed you on his video earlier. And that went really well. We were able to get most of it out, although it was very calcified. And I spoke to him just the other day. His vision's actually improved a little bit post-op. He does need additional hormone replacement therapy now, which despite all of the discussions beforehand, Mum has found hard to get used to. And he's fatigued, which is a thing that came up earlier. He's noticeably tired. He's back at school, but he's quite apprehensive in social circumstances, which again is something that we've said to her, it's early days. It's only 6 months. Things will probably improve over time. But relatively straightforward case. We could have anticipated some of the problems that were coming. We thought we'd communicated as much as possible with the family that this was to be expected. But when you talk to them, it's still something they found a little bit hard to take.
Yeah, and I think a lot of the therapy input was quite minimal with this young person. They were very physically able. But the visual loss was affecting their confidence and self-esteem kind of prior to the admission. And that was ongoing, and then kind of really, struggling with low mood and kind of, feelings of kind of, sort of being very upset about the whole situation, and lots of safety netting advice was provided to parents, and referrals onto the community occupational therapist, because one of the main issues that mum had identified was around the child not really wanting to engage in physical activities. So we did a referral to the community team and signposted to the specialist nurse and psychology for support around the emotional impact for this young person.
So moving on to a completely different part of the brain, completely different tumour. This is a little lad who we met with a history over a couple of months. He'd become more and more ataxic, difficulty with walking, becoming unsteady, progressing to the state of not being able to walk at all. I came into hospital just before Christmas in 2022, which was a bit rubbish for him, really, to be in hospital that time of year. And he had a scan that showed this large midline tumour, which we thought was probably a medulloblastoma in the middle of the posterior fossa. And he had a resection of that using what's called an IMRI-guided approach. So we used an MRI scan during the surgery to remove as much of it as we could safely, but knowing we were leaving tiny bits of it along the side, which is where there's most risk of damaging the brain round about. After his operation, he had ongoing hydrocephalus. He needed to have a shunt operation. And the other problem, Helen mentioned this earlier, was of post-operative mutism or post-operative posterior fossa syndrome. We had high apprehension ourselves that this might happen. David and I have done some work looking at the risks of mutism, and this was a young child with a medulloblastoma in the midline, and these are some of the highest risk subgroups for this. And his issues with this were very, very obvious. He wasn't speaking at all. He was not doing very much, and he was very emotionally withdrawn. And there's more to this than just mutism. It's not just about speech. There are other components to this that make it so very disabling. So he has needed an enormous amount of rehabilitation and support over the next couple of years. I saw him actually just yesterday for follow-up. He's still not speaking more than 2 years later. So this is one of the most profound effects of mutism that we've seen. And it's a very difficult thing for us to realise that we've caused. And this was despite surgery that was necessarily slightly limited to try and reduce the chance of it. And it's very, very difficult for the family to carry on when you have this going on, as well as the tumour journey.
Yeah, so he had really intensive rehab from us, which started with just positioning in bed, trying to work in different positions in bed. He was incredibly ataxic, so all movements were difficult. As Donald said, really emotionally withdrawn and really struggled to engage with the therapy team. And that was a significant battle for us in terms of trying to get rehab daily with him and how much he would be able to participate with that. So there was a lot of just trying to build relationships, build rapport and engagement with him and his family. We had a referral to orthotics to protect his joints, and was working on focusing and visual tracking to start off with. He had a long stay with us in hospital. And there was lots of liaison between centres regarding his radiotherapy, and him needing to have reached a level before we could get him safely to radiotherapy in terms of his rehab. And so there was delays in that because we just had so much work to do with him from a rehab point of view. He slowly progressed and started being able to sit with some support, and then independently carried on struggling with engaging at times, and we were thinking about how we're going to keep giving him rehab going forwards, and thinking about rehabilitation at the Children's Trust, which is inpatient setting down in Surrey. Was that an option, or was it referral back to local community therapists, and what was best for that family, and thinking whether an extended stay away from home was right or not. And so there was a huge MDT trying to coordinate that in various different centres, both in Nottingham, the Specialist Centre for Radiotherapy, and back home for him. So there's an awful lot of coordination went into sorting his package of care going forwards. Donald, you said he's on K walker now, so he is walking, but like we said, still not speaking.
So we're back in the pituitary fossa with a craniopharyngioma. I haven't chosen our easiest cases here. This is probably one of the most difficult craniopharyngiomas I've looked after in nearly 30 years. This was a lad who was 11 who presented to us, who was rapidly losing vision in one eye. And the emphasis from his family, understandably, was do something about the vision. He was really, really well otherwise. He was a little bit short, but his endocrine function was actually tested as okay. And all we had was a child with this very, very unpleasant tumour. You don't need to be a radiologist or a neurosurgeon to see on the bottom slice, the tumour has wrapped itself around the internal carotid arteries on both sides, including being wrapped around the optic chiasm. So a tricky tumour, but causing a degree of hydrocephalus as well upstream. We elected to try and get a diagnosis on this and debulk it with a craniotomy. And that was largely going well, with peeling the tumour off the internal carotid artery. And then during the surgery, he had some bleeding, which ultimately resulted in, although we got a pretty decent debulking of the tumour, he woke up with a dense stroke. So he woke up not moving his right face, arm or leg and not speaking. And this is one of these small print things that's on the consent form, that there's a risk of vascular injury. Ian talked about the small vessels as well as the large vessels that we can see. And if you're unlucky and you have areas of the brain that are devascularized while you're taking out some of a tumour like this, you can wake up with a complication that's on the list that's sort of expected or sort of anticipated, but not really expected for any of us. I'll let Rachel and Mel talk about rehabilitation in that context. You've got a family who thought they were coming in to have an operation to do something about vision, and we thought we were going to do that as well. But to everyone's horror, you've now got a young person with a dense stroke.
Yeah, so like Donald said, he had significant physical impact, a really low level of consciousness for quite a prolonged period. And so there were very brief periods when he was awake enough to be able to engage with the team. And when he did, we had a dense hemi on one side and then a very overactive other side that was trying to make up for the dense hemi. So it was quite complicated early phases in terms of trying to start his rehab up, and he had a really prolonged inpatient stay. Connected with that, he had a really short attention and concentration span. So he was a challenge in terms of keeping on task. And we, I think, used every strategy in the book and some that were not in the book as well, in terms of trying to keep him engaged in the sessions and trying to really give him very clear boundaries and short sessions to really get as much quality rehab as we could and make sure it was engaging and fun for him, and try to communicate that with parents who didn't think the sessions were long enough at times and were struggling with the fact that we were struggling to engage him and keep him on task. We had a complicated discharge, so there was home environment challenges, needing to get equipment in at home and stair rails and things like that. And so there was Mel was liaising with social services OT, a lot about sorting out adaptations. And they did go off down to the Children's Trust for an extended period of rehab, whilst all of that was ongoing. So parallel planning for discharge home, but also going to Tadworth for some more rehab. He continues to come to the ABI clinic, and he came a few months ago, and it was just delightful to see him. He's walking independently, still has a hemi, but he's independent, and there was a few words, so he can communicate his needs now, and he loves taking your hand and taking you for a walk. So that's what we used to try and do a lot. It's like, just go for a walk. So ongoing challenges for that young man, but has had a really good outcome from what started in a really challenging place.
And to date hasn't needed any more treatment for his craniopharyngioma as well, which is a blessing in the midst of all of this, although it's early days. Different theme. This was an 11-year-old girl who came in a couple of years ago, very precipitant admission with rapidly deteriorating conscious level, and ended up in the intensive care unit having an urgent CT scan, which showed a very large tumour on the right side of the brain, causing lots of midline shift, lots of brain swelling. So she had emergency surgery, in fact, twice over the weekend. She had an initial operation to move part of it, and then had some bleeding and had further operation to move a lot more of it. Then had some subsequent radiotherapy and temozolomide. It was a high-grade glioma, a really unpleasant tumour. And because of brain swelling at the time, she started off the process with a portion of the bone left out on purpose to allow for brain swelling. Actually, given that pretty miserable story, she's done fantastically from a physical point of view. The brain eventually sort of receded back inside where it should be. We've been able to put a cranioplasty over that. Everything's healed up. So on paper, in some respects, a really, really good outcome. But some of the difficulties here were things that were initially not that obvious to us, but which became obvious over the next week or two when we started looking after her. She had some pre-existing behavioural changes, and relationships were not straightforward within the family, either with her, with each of her parents, or the parents with each other. There'd been issues with things like school attendance and eating and so on beforehand. So there was a lot of things that, in the midst of all of the other obvious physical and neurosurgical challenges, there's an awful lot of sort of soft, sort of psychological and social issues in the background that contributed hugely to the difficulties of her subsequent journey.
And in terms of engaging with therapy, this young lady didn't really want to engage much with physio and OT. So we, again, made lots of different, efforts to try and engage this young lady. In terms of self-esteem, like really struggled with her appearance. Didn't really want to wear a helmet, which obviously we wanted her to for safety when she was moving around. Did engage sort of further down the line with neuropsychology for an assessment, and I have learned that she is back at school but needed a lot of support, and a very, very gradual return to school. And yeah, I think for her it was really around that sort of body confidence and self-esteem issues around the sort of results of the surgery as well.
So wanted with those cases just to show you really there's a multitude of potential problems. So as well as when we're looking at the scans and talking to families and thinking about the operation, we're trying to anticipate which of these things will come out of the woodwork and become the predominant issues afterwards. So a multitude of potential problems. From my point of view, one solution: to have a fantastic team of people like this who are funded to be there to work together, to look for solutions, and to be able to carry on the great work over what is. These are patients I've selected here that have got 2-3 year journeys in many cases. So thanks very much. And I think it's now going to be lunchtime unless we have any questions before then.